Hello there, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined by Dr. Ben Thrower, whose topic today is Ouch, MS Pain. There went my screen. After he's done with his presentation, we're going to open it up for your questions and comments. Now I'm delighted to introduce our speaker. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center, and he previously served as the medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for the Multiple Sclerosis Foundation, and he enjoys contributing to their quarterly Focus magazine. We're very pleased to have him join us today to present this important topic. Dr. Thrower, thanks for being with us, and I am going to turn it over to you.
Thank you very much. And thank you to everyone who's joining us today. Thank you to the folks behind the scenes at MS Focus. We appreciate all you do in keeping the wonderful programming up and running. So this is a topic today that I think will be of interest to many. There are quite a few symptoms we see with multiple sclerosis that are largely invisible, but have such a big impact on people's lives. I would say pain, fatigue, cognitive dysfunction. These are things that someone couldn't just look at you and tell that you're dealing with it, but obviously they can have, a huge impact on your quality of life. So when we think of pain, interestingly, we just take it for granted that the healthcare community has always acknowledged pain to be a part of MS, and sadly, that's not true. For years, MS was said to be a painless condition, and we know that that's clearly not correct, that there are many things about multiple sclerosis that can be associated with discomfort. In fact, about a half of people living with multiple sclerosis do deal with some type of chronic pain. So some of the things that we're going to touch bases on are different types of discomfort in multiple sclerosis, and we'll go more into these different sort of terms and what they mean. So we're going to talk about dysesthesias, we're going to talk about neuralgias, we're going to talk about spasticity and spasms. We have to acknowledge that not everything that's painful in someone living with MS is automatically from their MS, and we have to be wary of automatically falling into the trap of blaming everything on multiple sclerosis. And then we're going to talk a little bit about the role of cannabinoids or medical marijuana, if you will, in managing MS pain. So pain can impact a lot of different other areas of health in people with multiple sclerosis. If you're dealing with chronic pain, it can obviously have an effect on your mood. It can alter your sleep, which can then lead to more fatigue. We see poor attention and concentration. And, as much as we encourage people in the MS community to stay active and fit, if you're dealing with chronic pain, that's going to be tough to do. So we do see deconditioning as a result of chronic pain. So we're going to talk first about dysesthesias. So what does the word dysesthesia mean? So when we say esthesia, it means a feeling. So if you have a paresthesia, that means you have an extra feeling. It could be something like tingling, or there's water running down my leg, or there's a bug crawling when it's not there. If we put the phrase dys in front of that, it means it's an uncomfortable or a painful extra feeling. Unfortunately, a lot of the extra feelings that we see in multiple sclerosis go beyond just extra, and they become uncomfortable or dysesthesias. Some people might experience a burning or kind of hypersensitivity to touch. Some people describe it as a scalded skin or sunburned type sensation. Lhermitte's sign is a form of a dysesthesia. Lhermitte's sign is when you bend your neck forward and you get discomfort, maybe going straight down your back, maybe into your legs, maybe into your arms. So that is a form of a dysesthesia. The MS hug or banding can be actually a form of dysesthesia. This may also be a form of spasticity or spasming, and sometimes we struggle a little bit with which one it is. An unusual form of dysesthesia would be pruritus or itching. So, people say I get these horrible itching sensations, and might lead them to go to their primary care provider or dermatologist, which were always in favor of because we want to rule out non-MS causes, but sometimes the primary care provider or dermatologist says, we don't see anything there. This is neurological, and that's certainly a possibility that the itching may actually be a direct result of your multiple sclerosis. We also want to talk about some of the treatments as we go through these different forms of discomfort. When we think of treating dysesthesias, most of our treatments can be divided into one of two types of medications: anticonvulsants or antidepressants. So a lot of anticonvulsants, based upon their mechanism of action, could be useful in managing dysesthesias. So one of the ways that anticonvulsants sometimes work is they shut down some of the abnormal electrical crosstalk between nerve fibers. And that sometimes we think that's part of the problem in multiple sclerosis when we see dysesthesias, is that nerve fibers are communicating with one another in an abnormal fashion. So gabapentin or Neurontin would probably be one of the most commonly used anticonvulsants for managing dysesthesias. One of the challenges with gabapentin is there's a very wide dosing range. So gabapentin comes in a 100 milligram, a 300 milligram, a 400 milligram, a 600 milligram, and an 800 milligram dose. And so we see individuals who will get away with little tiny pediatric doses, whereas other people may need much larger doses. One of the nice things about gabapentin is it has very little potential for interacting with other medications, and it has no metabolism itself, which means it has very little potential to bother your liver or kidneys. Other anticonvulsants that are used are things like Lyrica or pregabalin, Tegretol, carbamazepine, Trileptal, or oxcarbazepine are all things in the toolbox. Antidepressants, again, based upon the way that they are designed to work chemically in the central nervous system, can also be used for pain management. One of the oldest medications around would be amitriptyline or Elavil. Its cousin is nortriptyline. When we use amitriptyline and nortriptyline, we're typically using them at doses far lower than we would use to treat depression. The problem with those old antidepressants, if you're really trying to use them as an antidepressant, is by the time you get to a dose that's effective for mood, the person's usually going to be pretty drowsy. We can use much lower doses to try to treat dysesthesias. These are typically just given as a once-a-day bedtime dose. If you're having some trouble sleeping, one of the side effects of these drugs is drowsiness, so sometimes they can help with sleep. We always want to make sure that that drowsiness is not bleeding over into daytime, resulting in you having some daytime drowsiness. Duloxetine or Cymbalta is actually FDA approved for pain management. Was very well tested in people with diabetic peripheral neuropathy, but it works well for dysesthesias in multiple sclerosis. And with duloxetine, we are typically using that at a dose where it would also be antidepressant. So we could get, to treat two different symptoms with one medication. Savella would also be an example of a medication that is an antidepressant used for pain management. If you have a fairly localized area of pain, maybe just 1 foot or both feet or just a patch on a part of your body, we might think about a topical medication. So Lidoderm patches is just transcutaneous lidocaine, a patch you see in the picture there, the guy has on his right shoulder. There are compounded medications. So you could have your physician or healthcare provider write for these medicines that are mixed up at a compounding pharmacist that will contain some sort of variation of gabapentin, lidocaine, clonidine, ketamine, a bunch of other things that can be put into these compounded medications. And then topical CBD. We'll come back to CBD again when we talk specifically more about the cannabinoids and pain management. And then for some people with really difficult dysesthesias, truly tough refractory pain, we might think about more aggressive things like a spinal cord stimulator. So this is almost like a pacemaker that's surgically implanted under the skin in the lower back area. Sort of very small electrodes are going to tap into the nerve roots in your lower back and send an electrical signal up to the spinal cord to try to override the pain signals that you're getting as a result of the demyelination from MS. This is a commitment. It is a surgical procedure, and you want to make sure that it's going to do what you want it to do before you put it in. So there is an external device, a test unit that you can try out to see if it's going to give you the pain relief that you want. Shifting to the neuralgias. So some people use the term neuralgia to describe dysesthesias in the rest of the body, but I'm using neuralgia really to describe pain above the neck. So these would be things like trigeminal neuralgia. The trigeminal nerve supplies sensation to your face. There are 3 branches, 1, 2, and 3. Typically, we see the most common pain with trigeminal neuralgia along 3 or 2. So the pain is going to be down in the jaw area or across the cheek. This pain is pretty severe. When people have bouts of trigeminal neuralgia, they would rank the pain usually at a 10/10 scale. Can be precipitated by chewing movements, by talking, something touching your face, even just a breeze blowing across the face can set off a bout of trigeminal neuralgia. Occipital neuralgia is typically on the back of the head. Your greater occipital nerve, you have one on each side, exits the base of your skull, and it supplies sensation to the back of your head or scalp. This pain is kind of a shooting, intense sort of pain. There can be hypersensitivity to touch. Like if you're brushing your hair, combing your hair, it might really set it off and be bothersome to you. So some of the meds that we might use for dysesthesias, you're going to see them pop up here again under neuralgia management. So things like carbamazepine, oxcarbazepine, some of the other anticonvulsants that we don't use in dysesthesias might be useful for these types of neuralgias. Phenytoin, lamotrigine, or Lamictal, even some of the antispasmodics like baclofen, clonazepam. We can think about Botox or glycerol injections. And then in the more severe cases of trigeminal neuralgia that are not responding to these medications or injections, we will sometimes refer to a pain institute or to a neurosurgeon to think about things like a gamma knife procedure, radio frequency lesioning, which is done through just where the trigeminal nerve exits the skull right here in front of your ear. And then there's a decompressive surgery called a Ginetta procedure. It's interesting that you would think about decompressive surgery because this is an old theory that still holds true. And some people, we think their trigeminal neuralgia is because of an artery sitting on the trigeminal nerve. And as that artery is pulsating, you're irritating the nerve. We don't think that's what causes trigeminal neuralgia in a person with MS. We think in MS, it's actually in the brainstem itself due to demyelination. But interestingly, sometimes this decompressive surgery, even though you wouldn't think intuitively that it would help, does work in people with multiple sclerosis. With the occipital neuralgia, we usually think about, there's an old anticonvulsant called indomethacin that sometimes works for this. All of the same options that we use in trigeminal neuralgia are on the table with occipital neuralgia. And then we can do an occipital nerve block. The greater occipital nerve as it exits the base of the skull is very, very superficial. It's very easy for a pain physician to go in and do a steroid, maybe lidocaine block at that area. When it works, it'll typically buy you about 3 months of pain-free time. Very simple procedure. So we're going to shift now to spasticity and spasms. Spasticity is actually derived from a Greek term, spastikos, meaning to draw or to tug. It affects the muscles, so it's a motor disorder. If I'm talking to a medical student, the official answer to your test question for a definition of spasticity is that it is a velocity-dependent increased resistance to passive stretch. Meaning that if I were to, let's say your arm is affected by spasticity and I'm going to slowly move your arm, I'm not going to feel as much resistance. If I were to move it very quickly, that arm is going to tighten up and you're going to really see the spasticity manifesting itself. You'll see exaggerated deep tendon reflexes or tendon jerks and as part of the physical exam. Along with these exaggerated reflexes, people can experience spasming, clonus. So what you see in the cartoon there is the healthcare provider is moving the person's foot up quickly. And what clonus would be is the foot then bouncing. You may be able to elicit this same reflex by just putting your leg in a certain position. If you're dealing with spasticity and you get your leg in a certain position and your knee starts bouncing up and down, that's clonus. What's happening is the deep tendon reflex. When we would say tap on your knee, normally your leg just jerks once. What you're doing with clonus is you're making that reflex fire over and over again in sort of an arc. There's nothing dangerous about it. It can be really annoying. If you move your leg into a different position, it will typically stop. But that's just in the family of increased muscle tone or spasticity. The spasms can be painful for people. If the muscles are tight enough, you may lose the ability to move those muscles effectively. You can have a sense of weakness or heaviness when really it's not true weakness. It's that the muscles are so tight that you can't move them effectively. So what is the difference between spasticity and spasms? Spasticity is the chronic state of the muscle being tight. A spasm is a wave of increased muscle tone. It's typically painful. So a lot of times people that have spasticity will also have spasms along with it, but technically they are slightly different things. So when we say spasticity, we assume that it's always a bad thing, and a lot of times it is, but interestingly, there can be some positive or effects or benefits from having spasticity. Some of those positive things is that if the muscle is tight, it is sort of exercising the muscle and you're helping maintain muscle tone. Some people use a little bit of spasticity in their legs to help with their walking. If you have weakness in your legs, and now you put a little bit of spasticity or the legs wanting to straighten out or stiffen, you may actually be using that increased muscle tone to help with walking and transfers. Sometimes when we take all of the spasticity away in people with weakness, we make the legs feel better, but we might actually impair the level of functioning. We might impair their ability to transfer from, say, chair to car, because now the person is too loose. We actually see a lower risk of deep venous thrombosis or blood clots in people with a little bit of spasticity. If their mobility is limited, but the muscles are tightening at times, especially if there's spasms, sometimes we think that actually may lower the risk of having blood clots. On the other side of the fulcrum there, these are all the bad things that we can see. They're painful, they impair function. A lot of times spasms act up during sleep, so they can disrupt sleep. They can make it difficult to take care of personal hygiene. One of the things we see with spasticity is the legs want to cross over one another. Makes it difficult to take care of cleaning yourself if the legs are crossed over one another. And if the muscles are tight for a long period of time and we don't do something to improve that range of motion, you can get contractures and the joint can become fixed in that position. When we think about managing spasticity, we think kind of a pyramid approach or sort of a stepladder approach. One of the first things we want to do in managing spasms and spasticity is remove anything that's irritating you, or noxious stimuli. We'll go over a list of what those things could be. Then we think about getting you in with a physical therapist. We want to make sure you've got a really good stretching program. Then we think about oral medications, things like baclofen, tizanidine. And then we think about more aggressive treatment, putting baclofen directly into the spinal fluid through an intrathecal baclofen pump. So these are some of the things that might irritate your body and cause you to have more spasming. I would say number one is urinary tract infections. If someone calls us up and says, my spasticity and my spasms are going nuts right now, I was doing pretty well on my prior medication, and now I'm not, the first three things we're going to think about is ruling out a urinary tract infection. Any of the other things on here, a shoe that doesn't fit well, having fatigue, having stress, any of these things can make your spasticity and spasms act up. So the oral medications that we typically look at, I would say number one is probably baclofen and tizanidine. These are interchangeable. They do have different mechanisms of action. We sometimes use them together because they do have different mechanisms of action. Your diazepam, clonazepam, lorazepam. So these are your benzodiazepines. These are really effective muscle relaxants, but probably not the first thing we want to reach for because they do have some potential for addiction and tolerance. Dantrolene is an old antispasmodic medication. We don't use it as much in MS as our colleagues who manage spinal cord injury do, but it is something that can be helpful. Keppra is one of those anticonvulsants. It's not useful for the chronic spasticity, but if you're having waves of spasms, it can sometimes help there. And then the cannabinoids, this is going to be your medical marijuana. Again, we'll touch more on these at length in just a moment. This is what an intrathecal baclofen pump looks like if you've never seen one. So when you take baclofen by mouth, it's absorbed in the GI tract, and a certain amount of it is going to go to your liver. Your liver is going to metabolize it, and you just excrete it. So a certain amount of the baclofen that we take by mouth never gets anywhere. You metabolize it, and it's just out of the system. A certain amount of the baclofen crosses the blood-brain barrier and actually gets into the brain itself. That's not where we want baclofen to work. We want baclofen working in your spinal cord. The baclofen that gets into the brain itself is where you're going to get sedation from. So ideally, you'd like the baclofen only working in the spinal cord. Well, one way to get a lot of baclofen at the spinal cord is to put baclofen into the spinal fluid. So that's what the pump accomplishes. The pump itself is about 3 inches in diameter. It's going to hold concentrated liquid baclofen and deliver that through a small tube that's going to come out into your lumbar spine. And it's adjustable. So the team that works with baclofen pumps is going to sort of set the dose and then adjust it as needed. Again, just like with the spinal stimulator, you want to make sure that this does what you want it to do before you commit to having it surgically implanted. So there is a test unit that is done first before you have the surgery. These pumps typically are going to last 5 to 7 years, and then the pump itself, not the tubing, but the pump itself is going to be replaced and a new one put in. So talking a little bit about cannabinoids or cannabis and multiple sclerosis, what is it? What do they work for? What does the science say about this? Cannabis is a complicated plant. There are over 480 active compounds, of which about 60 to 70 of these are a chemical class called cannabinoids. A lot of the other chemicals in cannabis are called terpenes, and these are being studied also. These don't have any psychoactive effects, but they appear to have a lot of anti-inflammatory effects. We're going to talk mainly about some of the cannabinoids and how we might use those in pain management. So if a cannabinoid, again, these are the chemicals in the plants, if it comes from the plant itself, we call it a phytocannabinoid. If it comes from your body naturally, and our body has an endocannabinoid system, that's where the phytocannabinoids work at. If it's a cannabinoid made by our body naturally, we call it an endocannabinoid. And then there are synthetic cannabinoids. Dronabinol is an oral medication. It is synthetic THC. It was FDA approved for nausea and chemotherapy patients, for extreme anorexia or a loss of appetite that you might see in a chemotherapy patient, or maybe with other health conditions. But it's a synthetic THC. So the two cannabinoids that we really spend the most time talking about would be THC and CBD. CBD is psychoactive, so we're going to talk about the good things we see with it, but we do have to acknowledge that it is psychoactive. You can get high from it, you can get anxious from it, whereas CBD is non-psychoactive. Probably the worst thing you could do with CBD is just make yourself a little bit drowsy, but you're not going to get high from CBD. There's a lot of confusion out there because of the different sort of plant names. So when we think about, cannabis itself, all of these are technically cannabis. So you'll hear people talk about sativa versus indica. These terms have gotten complicated because there are a lot of hybrid plants out there that really don't fall neatly into one of these classes or the other. But generally with sativa, we think of a plant that has higher THC to CBD, probably less sedating, a little bit more activating, whereas an indica plant has a higher CBD to THC ratio, is going to be a little bit more calming and sedating. Hemp was cultivated over thousands of years to have a thicker, more fibrous stalk than its cousins, and they were doing this for rope and paper production. When the process of cultivating hemp, unintentionally, the genes were sort of bred out of it to make THC. So by federal law, a true hemp plant cannot have more than 0.3% THC in it. A lot of different ways to get cannabinoids into your body. They can be smoked, they can be vaporized, they can be taken as sublingual oils, topical oils, gummies, lozenges, brownies, cookies, any number of ways of getting cannabinoids into the system. So where things again get a little bit confusing is when we think about CBD products. So CBD products are legal in all 50 states. CBD products are obtained from hemp. And remember, we said hemp cannot have more than 0.3% THC in it. We're talking in a moment about just another confusing factor that's come on the market. So CBD, again, is legal for purchase. You'll see CBD stores everywhere. When you see products with THC in them, if it's a Delta 9 THC, which is real THC from the marijuana plant, these are quote unquote marijuana plants, and these are going to be more tightly regulated. So CBD can be beneficial for anxiety, for helping with sleep. In my experience, if we're going to manage dysesthesias, neuralgias, spasticity, and spasms, we probably need that product that has more THC in it. So what does the science say about the cannabinoids and multiple sclerosis? There is data out there saying that they can be helpful for managing painful spasms. They can be helpful for dysesthesias. Interestingly, they can help with an overactive bladder as well. There's a lot of data saying that cannabinoids are anti-inflammatory, but no one has been able to take that leap and say that we can actually use cannabinoids as a MS disease modifying therapy. It's tempting to think that you could. If it's anti-inflammatory, shouldn't we be able to prevent relapses, new lesions on MRI, or slow disability? To date, no one has data that shows that cannabinoids do that. So we mainly think of these as being used in symptom management, most commonly pain management. So these are your synthetic agents that are out there. So dronabinol or Marinol. There's another one called Sesamet. These are, again, your synthetic THCs. So the other products that I just mentioned this one, this would not be something that we would typically use in multiple sclerosis, but Epidiolex. So Epidiolex was approved in 2018 by the FDA for certain refractory pediatric epilepsy types. It is just a concentrated CBD. It's a high dose of CBD. It's very effective, again, in certain seizure types. Sativex is from the same company, from GW Pharmaceuticals. This is a 1-to-1 CBD THC sublingual spray that has been shown in several studies to help manage spasms in multiple sclerosis. It is approved in a number of countries outside of the United States. Sadly, our studies here in the U.S. look like they're not going anywhere. So there was a study that was designed, in my opinion, with a bad outcome. They picked something called the Ashworth scale, which is a measure of spasticity in multiple sclerosis. No cannabis products has ever been shown to affect the Ashworth scale. And so it was a little mysterious why they picked that scale when the better measures probably would have been spasm counts. And because Sativex did not meet that sort of Ashworth scale outcome, the decision was made by GW Pharmaceuticals to halt the studies in the United States. So we don't know if we'll ever see Sativex. The appeal to Sativex was that it was a very high quality CBD THC product, and it would be FDA approved, meaning your insurance would cover it. So again, we've mentioned that hemp products are legal in all 50 states and that these have 0.3% THC. Where life has gotten a little complicated is here with these products called Delta 8 and Delta 10 THC. Again, the THC that is naturally obtained from cannabis is Delta 9 THC. So where does Delta 8 and Delta 10 THC come from? They are manufactured in a laboratory. So they take CBD and it is chemically converted into one of these two molecules, Delta 8 or Delta 10. So these are legal for right now. And as far as we can tell, they seem to have all the same properties as Delta 9 THC in terms of maybe pain control, or if someone's using them recreationally to try to get high, you can probably do it with Delta 8 and Delta 10 THC. The problem is how they're manufactured. So again, it's not a naturally occurring chemical. And so what these CBD manufacturers are doing is they're using things like toluene or maybe formaldehyde products to make that conversion. There have been several independent chemical labs that have looked at these Delta 8 and Delta 10 products and have found traces of the solvents used in that conversion still in the product that you're buying. And so I would just be extremely cautious if you're going to use a Delta 8 or Delta 10 product. I would do your homework and make sure you're buying from as reputable as a company as possible. Again, we would prefer it be the real deal Delta 9 THC because that is the natural phytocannabinoid from the plant itself. It's challenging in the United States because we have this patchwork of different laws. If you're looking at using a cannabis product other than just CBD, just know what your state laws are. And then finally, coming back to the point that not everything that hurts is necessarily MS related. So this guy came into the emergency room with a headache, and I think you can see from his x-rays what's causing his headache, clearly not his multiple sclerosis. So we have to keep an open mind to the fact that there are things out there. Just because you have MS doesn't mean you couldn't get routine wear and tear in your lumbar spine and have sciatica just like anyone else does. So we want to, again, always be mindful of that. And with that, I will turn it back over to Deb and the MS Focus crew, and we'll take some questions.
Okie dokie. Thank you. That was really enlightening. I was taking some pictures of your slides because I was like, whoa, I'm really learning about this stuff. This is great. Okay, so let's go this way. We are ready for questions now. I know that we have quite a few in our chat and in our other method. If you have a question or a comment and you haven't already put it in there, you can ask it by using the Q&A button in the app, which also allows you to send your question anonymously if you choose. You can also ask your question live by clicking the raise hand button or by pressing *9 if you're a phone user right now. I'll call on you and then you'll just have to unmute yourself to ask the question. So let's go here. Okay, so the very first question that came in was from Joshua, and he said, neurofilament. On exam yesterday, my doctor told me that my neurofilament was at 15.8 and then told me that 15.4 was the highest tolerance, leading him to say that I could have a relapse. He wanted your opinion.
Yeah, so neurofilament light chain is we've been talking about it now for probably the past 5 years or so. So what neurofilament light chain is, if you are damaging axons and myelin in the central nervous system, neurofilament light chain is released into the bloodstream and into the spinal fluid. So it is a surrogate marker for demyelination. And so there's been a lot of interest in how do we use this in clinical practice? Can we use it to say, how effective our treatments are? Can we use it to potentially predict a relapse? I would just be cautious. It's very interesting. In my opinion, I'm not quite sure it's ready for prime time yet. I think it's very interesting that your physician is going there. Obviously, they're kind of thinking ahead of the game and on top of what the literature is saying. I would certainly want to put that blood test result together with maybe MRI, with how the person's feeling. Are we happy with the disease modifying therapy that the person's on? So that's what neurofilament light chain is, and that's how we would like to use it, is to monitor how effective our disease therapies are.
Thank you. And Elizabeth is asking, is there a seasonal pattern to spasticity that's unrelated to weather?
Well, we do hear that in some people, this kind of, seasonal fluctuation. If you take just the humidity and the heat and cold out of it, I think there is something to that in certain people. It varies from person to person. We have individuals who say, man, I always do horribly in November. Could it be that it really is seasonal, or could it be that there's a lot of extra stressors, families coming in for Thanksgiving in November, and that it's more than just the month, but there are other factors. I will say, if we just look at temperature, so we know that about 75% of people with MS are heat sensitive, but a lot of people with MS are cold sensitive. And if something is going to act up, if you get excessively cold, it's probably going to be spasticity. So some people with MS do tighten up when they get chilled.
Dr. Thrower, Mike wants to know if you have any opinion on RSO products.
I'm sorry, on what?
Do you have any opinion on RSO products?
We have had patients use them. I don't know of any published literature. I've not looked for a while. So, sometimes there are studies that are coming out. I don't have any concerns about safety, those for symptom management. I would say I've not been blown away.
Okay. Joshua has another question. He said, in cannabis, does it have a negative effect on sperm motility? My wife and I are going through IVF, and I am hesitant to use anything cannabis, even though I would like to, but we hear about negativity towards sperm motility.
Yeah, that's a great question. And that is true. So in men using cannabis, it can affect both sperm counts and sperm motility. With heavier use, you actually almost get an estrogen effect. So you can see, guys just getting a little bit softer. We don't know what that threshold is. And so I would say, for the typical guy with MS who's using cannabis at maybe a bedtime dose, I don't think it's going to have a drastic effect on sperm motility. But when you get into heavier daytime usage, it's probably more of a concern. If someone's going through fertility testing workup, I would probably do what he's doing and avoid it, just to keep. That's one variable you probably don't want to introduce right now. Maybe wait until that testing is over and you have a better sense of where that's headed.
Good advice. Thank you. So we have an anonymous question. They say their hamstrings are tight. However, they don't experience pain, just heavy legs if they don't stretch. So is this the same thing as spasticity?
It is. And so spasticity and spasms can be painful, but they're not always painful. They can just affect function. And so when you have tight hamstrings, your legs can just feel heavy. When you kind of get up out of a chair, you may have to take a few seconds to kind of get your feet moving again. The person mentioned stretching, and we really want to make sure people are in a great stretching program. You really can't overdo it with stretching. Most of the stretching that we think of that we do is what we call static stretching. So you're pulling the joint into a certain position and holding it there to stretch that muscle out. There's another form of stretching that might complement that called dynamic stretching. So if you were to Google dynamic stretching near me, you'll find these different facilities that you could go to, and usually they'll spend 30 minutes having you work with a trainer, and it's a different form of stretching where they're doing it through range of motion. I can't say one's better than the other, but I do think the dynamic stretching for some people can complement the normal stretching that you do.
Maria asked a question, and then someone else on this call actually answered her question, but I'm going to go ahead and say it anyway because other people might be interested. She said, "Hello, I'm not sure what is meant by overactive bladder. What does that mean exactly, please? I can feel when I need to pee, but I have to quickly get to a bathroom. What is that called?"
That's an overactive bladder. So normally as our bladder fills up, there and is sort of stretching, there's a signal sent from the bladder through the spinal cord to the brain saying, hey, I'm starting to fill up. I'm probably going to need to go soon. The brain may say, you know what, I hear you, but you're not near a bathroom. You're going to wait a little bit. The problem with MS is you're disconnecting the brain and spinal cord from that bladder. So what's happening is the signal goes to the spinal cord, and because the brain is not having as much say as it wants to, the spinal cord is saying, just go right now. And so it's really, you get that strong sense of urgency. You may feel like there's a gallon of urine in the bladder, and you go, and it's like, that's it. And then 30 minutes later, you're doing the same thing again. So that's an overactive bladder.
Thank you. And Brian, I'm not exactly sure what he's talking about, but he said, what is the best strain?
So by strain, I assume he's talking about cannabis. It's not that there's a best strain. It depends on what you're trying to do with it. So again, if you have a product that's higher in THC to CBD, you're going to get pain control, and it's probably going to be a little bit less sedating. If you have a higher CBD to THC ratio, you can still get pain control, but you're probably going to have a little bit more sedation because of that higher CBD concentration. The trick with cannabinoid products, and this is probably true with prescription medicines as well, is there's tremendous individual variability. One person may be able to tolerate this much of a dose and someone else is this much. So just like we would do with baclofen or tizanidine, if we're using a cannabinoid product, we're going to start with a low dose and slowly titrate upwards until we hopefully see something good or we're starting to run into side effects.
And I think that sort of speaks to this question because Jamie wants to know, what CBD THC ratio have you seen most helpful with spasticity, tightness in legs? That's probably
really individual. I know one of the gentlemen that we've worked with in the past would typically start with a 24-to-1 CBD THC ratio, and then sort of go from there. So you're going then maybe to a 5-to-1 and then maybe to a 1-to-1. The Sativex product that is approved in other countries that we were testing here in the United States is a 1-to-1 CBD THC. Because there's no other option with Sativex. We would always start with a low dose and titrate upwards with that. Interestingly, one of the positive things about CBD is, when we're trying to manage pain or spasticity with a cannabinoid, we're not trying to get people high. We want you to have good symptom control, but still be able to function in a normal way, whether it's work or home. One of the things that CBD does is it seems to help blunt the psychoactive properties of THC. So it maybe lets you get more of the benefit from the CBD. But again, it gives, benefit from the THC without the high effect. But again, it's going to take just trial and error to find out what works best for you.
Okay. Both Maria and Debbie would like to know about acupuncture. One says, what's your opinion? And the other one says, can you discuss effectiveness of acupuncture for intense pain in lat or trap area, lots of spasticity that moves down to her hands.
So
So
there has been published data on acupuncture for spasticity management. It was actually in the spinal cord injury world, not MS, but if it works there, it should work in MS as well. So I'm completely open to people trying out acupuncture. You know, I think it's certainly been looked at for other types of pain, and I think there's data for other types of pain management. I think the risk is essentially nothing, so I'm very open to it. I would say probably in the same realm as a kind of similar idea is dry needling that a physical therapist might do, and we've seen this helpful. Not as much maybe for spasticity as for more musculoskeletal pain, but certainly something that physical therapists may pull out of their toolbox to try out.
thank you. Lisa wants to know if you ever prescribed fentanyl patches for MS pain.
Yeah, and I probably should have met, and we might add that to this next time. So what about opioids for pain management? So, you know, if we're going to use you know, an opioid, we would like to hopefully use it for a short period of time, but if we need to use it for chronic pain, we may be looking at long-term use. So we would like something that has a nice smooth response that stays in your system for a long time, so that there's a lower potential for addiction or tolerance. Fentanyl patches would fit that bill. So fentanyl's certainly gotten a bad rap, but from its, you know, recreational use. Fentanyl is an incredibly potent, you know, pain reliever. But if you know, someone is putting it into recreational drugs, whether people know it or not, you can very easily overdose and die from fentanyl. Not the case with fentanyl patches. So fentanyl patches are meant to hold 3 days worth of the medication. So you put one on, it's going to give you a slow, continuous release of fentanyl over a 3-day period. It wouldn't be something that we would reach for as a first line option for pain management. We're going to want to have exhausted all the non-opioid options before we go there.
Pamela would like to know if you think that certain foods, she gave examples of eggs and cheese, things like that, would they tend to give you flare-ups of pain, cause pain?
I think it's possible. So we do think that, you know, people with MS may have more food sensitivities. And again, there's going to be a lot of individual variability. So the people living with MS are going to have to do kind of their own detective work. If you think that certain foods might be triggering symptoms, whether it's fatigue or pain, it's going to be a process of elimination to kind of go through and see for you individually. I can't say for all the people that we work with MS that there's a, you know, that eggs, or I know there's a lot of concern about dairy. I think it's so individual, and you're just gonna have to try things out. I think one of the ways of doing that sort of trial is with sort of elimination diets. You can do elimination diets in one of two ways. You either say, okay, I want to see if eggs are problematic. Well, I'm going to get rid of them and, you know, try it for a couple of months and see if I feel better without it. Or I'm going to go without dairy for a couple of months. The other way of doing an elimination diet is with something like the Whole30 diet, where you eliminate a bunch of things all at once. And so with Whole30, you know, you can look that up. You're taking out dairy, a lot of sugars, alcohol, a lot of different things. And after a month, then after 30 days, that's the name Whole30, you're going to say, what of those things did I really miss? Maybe I really missed pasta. Well, I'm going to put that one thing back in. I'm going to see how I feel. If I feel okay, then I'll maybe go to the next thing and start reintroducing foods to see, well, what I might be sensitive to.
Okay, both Brian and Amanda are asking about spasticity. Amanda says she has terrible cramps and spasticity in the evening. So in her foot, so she wants to know what can be done. And he's saying that he's had MS for 30 years and still walking. What's the best thing for spasticity?
So the spasticity at night is unfortunately pretty common. And so a lot of people, you know, as they're kind of winding down, they're, you know, relaxing in the evening or trying to go to sleep, then the spasms will really kick up. And again, go back to, you know, when we talked about that that kind of step ladder when you think about managing spasticity and spasms. Make sure there's not something that's irritating it first off. Or do you have a UTI? Are you having excessive fatigue? Are you super stressed? If you can remove some of those noxious stimuli, do the best you can. Then we want to go to stretching. Make sure you've got a good stretching program. If those two things by itself are not working, then we're going to start looking at things like baclofen or tizanidine, or maybe medical cannabis. For her, where it's a foot that's involved, you could think about a topical. We talked about topical CBD for dysesthesias, but we've had some people say the topical CBD does help with nighttime spasming if it's a limited area, like just a foot. So you hopefully between all of those options, you'll find something that will calm that down.
Okay. And for Brian, what's the best for spasticity?
Yeah, same thing. You want to kind of go through that step ladder. So start with, removing the noxious stimuli, stretching, and then, if that's not doing it, what I do is I have a discussion with people and say, by the books, our next step would be baclofen or tizanidine. And I honestly don't think I see a big difference in the effectiveness between the two. The rule with both baclofen and tizanidine is to start with a low dose and slowly titrate upwards until you're either seeing good things, spasticity, spasm control, or bad things like weakness or sedation with it. So I present people with that option. I also present people with the medical cannabis option. That's gonna, whether that's an option for you is going to depend partly upon what state you live in. When we talk about medical cannabis, we have to be honest too and say there's a financial issue there. So I can get your insurance company to pay for baclofen or tizanidine. There is no insurance coverage for any of the medical cannabis products. And I think our patients that are using cannabis for various symptoms are probably spending on average probably $150 to $200 a month. And so we have to factor that in.
And Denise said, as far as her back pain, because she has chronic back pain, is there a starting point for pain relief resources? Ibuprofen isn't, strong enough anymore. So, as far as looking and starting for pain relief, would you suggest also the cannabis?
Good. That's certainly an option. So with back pain, low back pain by itself is usually not a direct result of multiple sclerosis. It might be an indirect result. So if the mechanics of your walking is thrown off a little bit, if you've got maybe foot drop, you're swinging a leg out, or if you're not walking much, if you're spending a lot of time seated, that can certainly, you lose some core strength and you can have more low back pain. So, when we think about low back pain, assuming there's not a lot of nerve root type symptoms. If the pain is staying in their lower back, it's more likely musculoskeletal. We can think about the anti-inflammatories like she's doing. We can think about topical anti-inflammatories, things like the Voltaren gel or diclofenac gel that used to be prescription, now it's over the counter. Some people get good pain control with that. Lidoderm patches would be another topical option for low back pain. Then we I like to get physical therapy involved pretty early in people with low back pain to see how much of it we might be able to relieve with that. And then we kind of go to some of the same things we talked about with dysesthesias. Your anticonvulsant, antidepressant type medicines can be used for low back pain. Medical cannabis can certainly be used there. One of the questions that comes up from a lot of people with low back pain is, do I need an MRI of my lower back? And realize in most adults, if we were to do MRIs of the neck and back, most of us have an abnormal MRI of our neck or back. Most of us have some degenerative wear and tear. We'll see disc bulges and bone spurs. That's not necessarily an indication that abnormality in MRI is causing your back pain. So again, most of us have it, but most of us don't have low back pain. The other thing when we start thinking about MRIs of the lower back, is why are we doing an MRI of the lower back? Really, it gets down, we're really looking for something for a surgeon to fix. And so if I talk to someone, they say, listen, I don't care what my MRI shows, I don't want surgery on my back. You could argue, well, why are we doing the MRI then? When we think about, managing low back pain too, I divide people with low back pain into people who mainly have back pain and people who have back pain and sciatica. If we're ever entertaining referring someone to a surgeon, the person with sciatica type symptoms is always the better surgical candidate. The data is very clear that those are the people who have good surgical outcomes. If the person has mainly low back pain with minimal radiation into the legs, that's a bad surgical candidate. And those are the people that you hear about that have a surgery and they get worse, and they have another surgery and they get worse still. So surgeons have gotten very good about being selective and thoughtful in how we think about who's a good candidate for surgical intervention.
Great. Autumn says she may have missed the discussion about TENS units, but I was wondering if it helps to alleviate neuropathy pain.
So TENS have usually been more helpful for just kind of more routine musculoskeletal pain. I've not seen them to be of great help for the dysesthesias or the neuropathy type pain. I'm not opposed to someone trying it. It's certainly benign. I wouldn't want to see someone spend a boatload of money out of pocket until they at least given it a trial before we try to get insurance coverage or have them pay out of pocket for it. But I've not been overly impressed with TENS for neuropathy pain.
Felicia is asking, she said she uses THC and takes a sertraline. I have an old bottle of tramadol I take occasionally since it zaps pain out of me for several days. I've tried the others you mentioned and they make me high until 3 p.m. So no go.
Yeah.
The amitriptyline and Nora, forgive me for not saying these right, nortriptyline about killed her. What are your thoughts on pain treatment I am doing and on the pain treatment she's doing and the tramadol as well?
So if she's getting adequate pain control with, taking an occasional dose of tramadol and then using some sort of THC product, if she's happy with that, I don't have any problem with her doing that. I would like to keep the tramadol to a minimum. Just it's sort of it's not really an opioid, but it does work at some of the opioid receptors. So it's got a little bit of addictive potential and potential for tolerance. It sounds like she's really given it a shot with a lot of the other things. So this would be a person that if we got to a point where we're not completely happy with the degree of pain control she's getting from THC and tramadol, and she's tried a lot of the other maintenance drugs, this would be someone I might refer to a pain clinic to say, okay, is this a fentanyl patch or a Butrans patch, which is another long-acting opioid, or is this a spinal stimulator candidate? Usually there are other options. One of the things that we didn't mention today is that some of the pain clinics can do is a little bit more outside the box, things like ketamine infusions. So there are things that are on the cutting edge that could be options if her current regimen's not working out.
Right. Heather says that she's asking, how often do you see spasticity in the upper arms and shoulders with constant pain, shooting pain, frozen movement, and waking up, not being able to pick up her arm?
So the upper extremities are certainly affected. It's spasticity is more common in the legs. And when you think about the pathway, the motor pathway from brain to spinal cord to legs, there's a lot longer pathway from your brain to your legs than there is to your arms. So it's a lot easier for MS to pick on something along that pathway just because there's more real estate. So spasticity is more common in legs, but arms are certainly affected too. The challenge with spasticity in the arms is as people get tight, sometimes it starts affecting their shoulder. And the shoulder is a funny joint. A lot of the integrity of your shoulder joint is muscle. So if you start having tightness from spasticity in your shoulder and you lose range of motion, you can get into this vicious cycle where the loss of range of motion is causing more pain, the pain is causing more loss of range of motion. And so you can actually end up with a frozen shoulder. We have an upper extremity clinic here at Shepherd, and the orthopedic surgeons who run that actually use the term MS shoulder because they see it commonly in our folks. That's where working with a good physical therapist can help head that off at the pass and make sure we're keeping good range of motion at that shoulder joint.
Perfect. We have an anonymous question, wondering why kidney stones aggravate spasticity. Kidney stones were an incidental finding by a CT scan for me during a hospital visit, but they are asymptomatic currently. Would just having them cause worsening MS symptoms?
Yeah, that's a great question. And I should have qualified. It's really the symptomatic kidney stones. So a lot of us, will pick up kidney stones on a routine CAT scan or ultrasound. As long as they're staying put in the kidneys and they're not obstructing anything, it's when kidney stones drop into the ureter, the tube from the kidney down to the bladder, that's when they're really painful. That's a very small tube, and you'll get the, with kidney stones, when you're passing one, you get these waves of, horrible, childbirth like pain. And so it's really only the symptomatic kidney stones that will kick off spasticity and spasms.
Mary she says, recently started on Prolia for osteoporosis. The past 10 days after the shot, I've had severe spasms during each day. Prolia can cause musculoskeletal pain. I've attributed the increase in intensity of spasms to the Prolia. The spasms are less frequent and less severe now. Was wondering if I was having a pseudo relapse, a relapse, or something else.
So I don't think this would be a true relapse. I think her term she used, the pseudo relapse, would be a better way of categorizing it. So something has provoked her old symptoms to act up a little bit. UTIs would be the most common cause of pseudo exacerbations or pseudo relapses, but certainly medication changes. With a drug like Prolia, you are seeing some shifts in calcium. When you get a dose, that's what it's supposed to do. It's not crazy to say that that could cause a temporary increase in spasticity. I think what she's going to have to do is look at the risks and benefits. So there's nothing dangerous about what she's going through. She might have to adjust her medications temporarily after a Prolia dose, but if she's got enough osteoporosis that someone was thinking about Prolia, the benefits are probably going to outweigh the risks.
Joshua is thanking you for answering his other questions. He also said he's considering acupuncture in coordination with his physical therapy to help address back pain and spasticity. He says, I haven't found any published studies, but is it recommended, and is there a specific type of acupuncture that I should pursue?
Yeah, and I will confess, I am not expert enough on acupuncture to know about the different types. So I know the website that we use when we look up data is PubMed, PubMed. So that's the repository for any peer-reviewed article that's been published almost in the for the past 200 years. So you can go on that site and just search, type in acupuncture and spasticity, and you should pull up anything that's been published. I know it's been a few years. The article I'm thinking of is at least 20 years old.
Dr. Thrower, are there any MS pain symptoms that directly correlate with possible PML infection?
Oh, good question. So PML is not thought of as typically as a painful condition. So, for everyone's reference, so progressive multifocal leukoencephalopathy is caused by JC virus. It's the side effect we never want to see. It is associated with some of our MS drugs. Most commonly, we think of it as a potential rare risk with natalizumab or Tysabri. Usually it presents in more of a stroke-like fashion. So it's going to be weakness, sensory loss, cognitive changes. If pain is associated, it would be minimal, I would think.
Do you have time for a few extra? I know we're at the end. Do you have a time for a few more? Or do you have to run?
How about we do two more?
Okay, good enough. So Ms. Coleman said, I'm on my third week of Celebrex for chronic back pain, 200 milligrams twice a day. How long before pain relief?
So with drugs like Celebrex, it usually takes about 5 days to hit a steady state. So 5 days at a minimum. Ideally, with maintenance medicines, whether it's Celebrex or nortriptyline or gabapentin, I like to give it at least a month to really say if it's going to work or not. But again, at a minimum, 5 days to hit steady state.
Okay. Lori said she's had leg spasms for many years with her MS, over 20 years. She recently started with her hand drawing into like a cramp that she needed to bend back and massage. Is this a form of spasticity?
It is. And so with spasticity, the legs are going to want to tend to want to extend. The upper extremities are going to want to flex. And so one of the ways that spasticity can act up in the hands is exactly what she's describing, where the fingers want to curl, especially at night. So what she's doing with the stretching is perfectly reasonable. So just like you would stretch any other body part, you want to stretch in the opposite direction of the way the spasticity wants to go. So if the spasticity wants to do this, you want to do this. If it is problematic at night, she can work with an occupational therapist. They can put together some nice hand splints that would just keep the fingers extended. So you're just passively stretching them at night.
Thank you. So for everyone else that has not, because we're at the end of our time, for anybody that didn't have their questions answered, Dr. Thrower every other month does a 1-hour Q&A where he will answer as many, he's the Energizer Bunny, so as many questions as you have, and pretty much any question that you have. So his next one is on the 8th, which is Tuesday of August, and that's at 4:30 in the afternoon. So if you can jot that down and you want to come to him with your question, I'm sure he'd be happy to answer it then. But that does bring us to the end of our time. If you've missed, and this was a question earlier for people that have missed this and they would like to see your slides again. So if you've missed any part of this, it has been recorded and it's going to be available through the MS Focus Facebook and YouTube channels. Please reply to your registration email for information on how to access recordings or to sign up for our newsletter to learn about the upcoming events that we have. Also, you'll be receiving a short survey when you leave the conference. We greatly appreciate your feedback, which helps us not only determine what type of information is most helpful, but also what's meaningful to you. Our next teleconference will be Wednesday, July 19th at 6:30 p.m. Eastern. Our guest is going to be Dr. Aaron Boster, and he's going to be participating in one of those 1-hour Q&As. And we titled those, when Dr. Thrower and Dr. Boster do it, Ask the MS Expert. So our sincere thanks to all of our attendees for your participation, and especially to our Dr. Thrower, who takes time out of his busy schedule each and every month to help educate all of us. Enjoy the rest of your day, everyone, and we'll see you next time. Thank you. Bye.
Thank you.